So, good morning, and thank you to everyone for joining us today for Henpick's Lunch and Learn webinar. My name is Michelle Gascoigne, and I'm delighted to be joined by Dr. Abbie Laing of My Menopause Centre, who have been rated outstanding by the Care Quality Commission to talk with us today about progesterone intolerance. So Dr. Abbie will be answering questions at the end of the presentation, but please do note that whilst Dr. Abbie will not be able to give specific individual treatment advice, she will endeavour to answer as many questions as we can. So please join me in welcoming Dr. Abbie Laing of My Menopause Centre. Good morning, Dr. Abbie. How are you today?
Good morning. Very well, thank you, Michelle.
Thank you. So, Dr. Abbie, we hear from many who are taking progesterone as part of their HRT, hormone replacement therapy, that they're experiencing some symptoms that could be due to progesterone intolerance. And in fact, only yesterday we received quite an emotional email from someone who's been managing this for quite some time. But before we go into the subject of progesterone intolerance, I think it would be really helpful for everyone on the call to understand a little bit more about this particular hormone. So, progesterone, what is it?
Yes, great first question. So progesterone is a hormone that is produced by our ovaries, and it has an important role in that it affects the lining of our womb and therefore has a role with our monthly bleed. And it is one of the hormones that declines as we go through the menopause transition. And it should be given to all women who are taking estrogen replacement who still have their womb. And the reason for this is that estrogen stimulates the lining of the womb to grow, and progesterone reverses this, keeping the lining of the womb thin and healthy. So if a woman with a womb was just taking estrogen on its own, it'd likely feel better, but that womb lining could be growing. And if it was left without a progesterone, this would increase the risk of womb lining thickening and therefore womb cancer. So progesterone is given as part of HRT to keep that womb lining thin and healthy.
That's a really good explanation. So thank you very much. So as you've said, it's not everyone that's on HRT that takes this, but we do hear of others who don't have a womb that are still prescribed or seek to take progesterone. Why is that, and what are the benefits?
So only individuals who still have womb lining need to take a progesterone. And so anybody with a uterus must take it, but sometimes people have had a hysterectomy, but still have womb lining left over, and that needs to be protected. And those people are, for example, people who have had a subtotal hysterectomy, which means that the womb has been removed, but the cervix is left in place. And sometimes the cervix still contains residual endometrium, residual womb lining. So that might be a case when progesterone is still needed. And sometimes people have had a total hysterectomy, so their womb and cervix removed, but have endometriosis. And endometriosis behaves very similarly to the womb lining. And so for that person, they may need a progesterone too.
Right. Okay. So when we talk about progesterone, we often refer to it as the calming, the sleep-inducing hormone. So are there times when progesterone, outside of the criteria that you've just described, that progesterone can be supportive to somebody?
So occasionally we have ladies that don't need a progesterone because all of their womb lining has gone and they don't have their cervix or they don't have endometriosis, so they don't need it, but they still choose to take it. And this is outside of the product license. But for some people, and I usually say around 10% of people, taking body identical progesterone is calming and helps with sleep. Body identical progesterone means that that progesterone is a replica of the structure of your natural progesterone produced by the ovaries. And what we know is that body identical progesterone is broken down in the body to something called allopregnenolone, which activates the GABA receptor and helps somebody to sleep and can reduce anxiety.
Right.
And I find in general that helps about 10% of women, but equally, although it can help 10% of women, about 10% of women have progesterone intolerance, which is where they don't get on with it, and 80% of women feel no different on it. So you'll hear very mixed stories. Some people will feel really, really well on body identical progesterone, and some people will feel awful on it. So you can have mixed responses.
And this is why it's so important to seek that medical guidance, because sometimes people can be really pushing the fact that progesterone can be supportive, and as we'll cover in a moment, actually for many in those percentages you've quoted, it really is very unsupportive during this menopause journey. So when we're talking about progesterone, and you've just mentioned that word bioidentical, how can we take progesterone? How does it present itself? What are the options?
There are lots of different progesterones to choose from out there, and they vary in structure from body identical, which means that progesterone is exactly the same as the progesterone produced by your ovaries, and that's called utrogestan or micronized progesterone. It's all the same thing. And they vary in structure depending on how similar they look to testosterone. So there's a scale of progesterones, with body identical being your exact replica of your natural progesterone. And body identical progesterone has come from the root yam vegetable, and there is a molecule in the root yam vegetable that looks very similar in structure to cholesterol, and scientists have been able to manipulate that into body identical progesterone. And in our body, naturally, progesterone is made from cholesterol, so it goes cholesterol to progesterone. So that's where the scientific advance has come from. And that's a very popular progesterone, and that is the progesterone that is considered to be one of the most breast friendly, has neutral effects on lipids, and for some women, 10% of women, can be sedating and reduce anxiety. And then there are lots of different other progesterones that all vary slightly in their structure and whether they're similar to progesterone or more similar to testosterone. And so the one that's quite similar to body identical progesterone is dydrogesterone, which is found in femistone. And then there's the marinocoil, which has levonorgestrelin, which is somewhere in the middle in that difference in structure. And then there's other ones such as desogestrel and norethisterone, and those are more similar in structure to testosterone. So you'll see there's lots and lots of choices, and because of this, they all vary in their side effect profiles because they're all slightly different in structure. And traditionally, body identical progesterone is thought to be the one that people get on with best. However, I still do have some women that don't get on with it at all, but do get on with other progesterones.
Wow, it's certainly a complex subject indeed, and hence again, that please do take the right medical advice and guidance when considering this. So bioidentical is the one that's most often prescribed, but how does one take it? You've mentioned the marinocoil, but how else do you take or administer progesterone?
So if I start with the body identical progesterone, it gets very confusing because there's lots of names for the same thing. So body identical progesterone is also called utrogestan, and it's also called micronized progesterone. And it comes in little capsules. I'll show it to you. I've actually got some here, so I might be able to just bring it to the screen. Yes, this is body identical progesterone utrogestan. I can show you that there.
Perfect.
Little yellow capsules. They look like little peas. Scientists haven't been able to make it small enough yet to go into a patch or to be used as a cream. We'd really like to do that, but at the moment we can't get it across the skin. So body identical progesterone has to be taken as capsules, and they have to be taken in the evening because they are sedating, or they can be sedating for some people. So capsules taken at night, and depending on whether you're perimenopausal, so whether you're still having periods, or postmenopausal, you would take it either as 2 weeks on, 2 weeks off. That's for someone who's still having periods, or 2 weeks in each calendar month. Or if you're postmenopausal, you take one every single night. So the way you take it depends on whether you're still having periods, and that's body identical progesterone. There is the marinocoil, and the marinocoil has a progesterone in it called levonorgestrel, which is slightly more similar in structure to testosterone, and that is put into the womb. It's a bit like having a long smear with some cramping moments, and once it's in, it lasts for 5 years. So that's the progesterone arm of HRT done for 5 years, and you use your estrogen separately. And some people with progesterone intolerance get on with that a little bit better because it's working locally in the womb. So there's lower levels of the progesterone in the bloodstream compared to swallowing progesterone or using it in a patch. Progesterones do come in combination patches. There's a combination patch called Everal Conti or Everal Sequi. There's another one called Fem7 Conti and Fem7 Sequi, and they both have different progesterones in. One of those, the Fem7 brand, has levonorgestrel in. So somebody could use that to see if they get on with the same progesterone in the coil before having the coil done, for example. The other one has a progesterone in called norethisterone. So you'll see that there are lots of different ways. It's more than just capsules. Progesterones come in patches, they come in coils, they come in tablets, they come in capsules. But probably first line, it's usually body identical or the Mirena coil for a person.
Right. Okay. Yeah. Progesterone is certainly a complex hormone when we're looking at it as part of HRT, isn't it? So that's really helpful to understand. Can we just very briefly touch on these synthetic progesterones that people often refer to,
Yes.
and how they come about? Because you've mentioned that obviously progesterone comes from the yam, whereas presumably synthetic is, as it says.
Artificial, that's right. So there is only one body identical progesterone, which is the utrogestan micronized progesterone, this one. Anything that isn't that means that it's synthetic, which means that it's artificial and a different structure to your natural progesterone. And there are some benefits, but also some disadvantages to synthetic progestogens. The benefits are that in general, they control bleeding a bit better for people. So people get less breakthrough bleeding when they use synthetics. The downside is that they're less breast friendly. They usually have a small increased risk of breast cancer compared to body identical, and they can cause negative effects on lipid profiles. And whether or not somebody has progesterone intolerance is very variable. I have some people that really, really don't get on with body identical, but do get on with a synthetic, and vice versa. Some people that really don't get on with a synthetic, but get on very, very well with body identical. Everybody's extremely different with how they feel compared to the two types of progestogens.
Okay, so again, seeking that help is so important, isn't it? That correct guidance.
Sometimes you'll hear the word progesterone, and sometimes you'll hear the word progestogens. So slightly different, progesterone and progestogen. Progesterone usually is referring to body identical progesterone, and progestogens is more of an umbrella term that synthetic progestogens fall into, of which there's many.
Right. Okay.
Gets quite
All right. Well, that's yeah, absolutely, absolutely. But again, make sure you're reaching out to get that help. And there's some great information on my Menopause Centre's website talking around these. And also, Dr. Abbie's done some sessions for us on Henpicked in other lunch and learns. You've mentioned, because the subject today, progesterone intolerance, and you've mentioned one area of symptoms, heightened anxiety, perhaps poor sleep, i.e. the complete opposite of the expectation. But when we're talking about progesterone intolerance, what are we actually referring to? And what are the type of symptoms that might indicate that someone is intolerant to progesterone?
And so when I take a history, I always screen for progesterone intolerance in a person's history. So if I'm speaking to somebody and they're saying, I've tried contraceptions in the past and I really just didn't get on with them, Abbie. And actually, I feel worse in the week before my period, and that's when your progesterone is high. It starts to raise flags for me that this person might have some progesterone intolerance. So I always screen for it. Looking back, people often go, gosh, yes, I've never got on with progesterone. I didn't pick up with it. When I was 24 and I was on the pill, I had to stop it. I didn't like it, or I didn't like the mini pill, or I've never got on with the coil. And you think perhaps this person's been progesterone intolerant and not realized it in the past. And 10% of women are. So 1 in 10 people will have progesterone intolerance. And then when somebody takes a progesterone, if they do have progesterone intolerance, they can either have physical or psychological side effects. So I split them into the two boxes. And psychological side effects happen because of progesterone receptors are abundant in our brain. So they're in our cerebellum, they're in our cerebral cortex, hippocampus, and hypothalamus. And they can be mild and they can be very, very marked. And they include anxiety, irritability, restlessness, panic symptoms, depressed mood, poor concentration, forgetfulness, lethargy, and then at their most extreme, suicidal thoughts. And some people, I have had some patients who have taken progesterone and ended up in A&E with suicidal thoughts. And then as soon as you stop the progesterone, things get better. So psychological symptoms can happen, and physical symptoms include those associated with fluid retention, so such as bloating, weight gain, abdominal cramps, nausea. Headaches can happen, migraines, effects on skin, so acne, greasy skin, dizziness, and breast tenderness can happen too. And sometimes people can get change in bleeding pattern.
Okay, so it very much is something that we need to be aware of. And as you said, when you're speaking to people, you ask for a little bit of background, a lot of background on what they might have experienced at a younger age. And so as progesterone occurs naturally, we could actually be intolerant by definition to our own progesterone. And as you said, that poor skin, and I mean, I think back to, riddled with acne for, 15 years, and, poor skin and bloating and all of those things. So never even sort of thought about it. So that once again emphasizes the importance of just spending that time to just think back to when we were in our younger years, and how we might have reacted to something like the contraception pill, whether it be a combination or a total progesterone. So if there are people listening today who are concerned, so there's light bulbs going off and people thinking, yeah, that actually, do you know what, that's me. And so they're thinking they might be experiencing progesterone intolerance. What are their next steps and where should they be going to for help and support? And I assume, one of the guidance is do not just stop taking what you're taking.
Yeah, that's right. Yes, you have to be careful because progesterone is, in my opinion, the nuisance hormone. Estrogen is the hormone that makes people feel really good, and progesterone is the one that sometimes doesn't. And so it's important to get a progesterone into a routine because it's important because it prevents endometrial cancer. So we're always trying to get the right progesterone for that person because it's your safety hormone, really, because estrogen makes that lining of the womb grow. So it's important not to just stop it and use estrogen, because that would be dangerous. Now, if somebody has mild symptoms, so say somebody's just started their HRT and they're thinking that they've got some mild symptoms, actually often they do improve with time if they're mild. And so if somebody thinks they can tolerate it, I say give it 2 to 3 month period, and often they go. And for many women, they get better just with time. But when somebody is truly progesterone intolerant, you pick up on it, and they're really struggling quite quickly, usually, when they've introduced a progesterone. And there are a number of possible options that can help. So usually my first option would be to change the progesterone. And it's absolutely incredible how people can feel really, really different. So for example, I've had somebody recently who was on body identical progesterone, wasn't getting on with it. We then tried the coil. Unfortunately, she didn't get on with the coil, so we had that removed. And I've actually moved her on to something called the mini pill. And the mini pill is, you'll have heard it for contraception, and it's not actually licensed for HRT, but you can use it at a double dose. So you can use 2 mini pill dailies, and that is enough to provide endometrial protection because it's found in other contraceptions. So we tried this for this person, and she is perfectly well on 2 desogestrel, so 2 mini pills, got no side effects whatsoever. So we tried lots of other ones, all side effects, and we found one that works for her. And so usually I try different ones, and unfortunately it is just trial and error at that point, trying a progesterone to see if you get on with it. If you don't, stop it, let's try another one. And normally we do find one, but occasionally you have people who are intolerant to them all. You can use body identical progesterone by the vaginal route. It is off license, but it is supported by the British Menopause Society. And we have some data that's been extrapolated from IVF data that shows that that is enough to provide endometrial protection. So you can use the same natural progesterone, so body identical progesterone capsules at the same dose by the vaginal route. And for some women, that takes away side effects, and it's because the metabolism is different. So when you swallow progesterone, it goes into the gut, it will get absorbed by the gut wall, and it will get broken down by the gut enzymes into different metabolites. When you put that progesterone into the vagina, those enzymes are different and it doesn't get broken down into those same end metabolites. And so if someone is intolerant to the metabolites, using it by the vaginal route takes that away. And I do have good responses for people using progesterone vaginally. You can use the same capsule, or there are vaginal pessaries that are designed for vaginal use that can be used and that contain body identical progesterone. So, for example, Lutigest is a vaginal capsule that has the same dose of body identical progesterone in. And if somebody has tried all of those and we haven't managed to get progesterone on board, at that point, you can consider reducing the dose, but it should be done under a menopause specialist. So it should be, if you're on the NHS, it should be referred to your local NHS clinic, or I do have some people privately who I reduce the dose with. And when you reduce the dose, it can help with side effects, but you can't be certain it's adequate to be protecting that womb lining from growing. So I usually come to a shared plan with the person about doing an annual ultrasound scan to keep an eye on that womb lining. So, for example, I have a lady on the NHS this week who was using progesterone for 4 days every 6 weeks. So that's a low dose progesterone, but she's having an annual ultrasound scan and we're keeping an eye on her endometrium. And she feels she's able to take it at that dose, and it's certainly better than nothing, but we can't be sure her endometrium isn't growing. So there's a backup plan. And there is something called quarterly regimes, which we sometimes use. And this involves using estrogen for 3 months on its own, and then having 2 weeks of a progesterone. And it means that you use progesterone 4 times a year, and it induces a bleed. And again, that means that for most of the time women feel well, and they have 2 weeks that they plan around where they don't, where they use the progesterone. And for those women, again, we do an annual ultrasound scan to keep an eye on the lining of the womb. So anything where you're reducing the dose should be done under a specialist setting for that reason. And then in very, very extreme cases, say for very severe progesterone intolerance, and we do sometimes have women that can't tolerate the quarterly regimes, you can be considered for a hysterectomy to remove the womb lining and use estrogen only HRT going forward.
Okay, so yes, because as you say, it isn't unusual, but for people to be severely intolerant, but they can go through.
Yeah.
I mean, I referred to an email earlier and I shared it with you, and that lady has clearly been struggling for many a long time, and the impact and some of the side effects you mentioned, she also described as experiencing. So if we've got people who are selecting maybe not to take HRT as part of their menopause journey, but are taking some of those herbal approaches or complementary medicines that are deemed to contain formats of progesterone, and as we've said, progesterone comes from a natural source. Can these help or hinder, or is it another one where there just isn't the research to support one way or the other?
So unfortunately, there's a lack of research on herbal treatments and non-hormonal alternatives. I have had some ladies who have been using progesterone across the skin, or a cream version of progesterone, and have come and said, gosh, I actually feel okay on this. And that's very concerning, and I wouldn't recommend using it there. We cannot get body identical progesterone across the skin. Other progesterones we can, so synthetic progestogens we can, but not body identical progesterone. We just cannot make it small enough. So there is a worry that some people are purchasing body identical progesterone creams and using that with our estrogen, but actually that would be unopposed estrogen, because that progesterone isn't getting across the skin, which is why they actually feel well on it, because it's not going into their body, if that makes sense. So there is some concern at the moment about that being purchased in the herbal sectors.
And that leads us on to one of the questions that have come in, and whenever we do a subject around HRT, you know, the impact of some of the shortages and some of the references that you've made, where progesterone can be present in a patch, does tend to be those names that we hear are in shortage. So there has been, you know, many points raised about when somebody's GP has just changed when and how and what somebody's taking, maybe moving from end of cycle to mid-cycle, prescribing different types, often due to shortages, or maybe sometimes down to just a lack of understanding of the complexity of the subject. And this has then resulted in many of the symptoms. So whilst it's not maybe deemed as a progesterone intolerance, actually the way that they are being prescribed and taking it is giving the results or symptoms similar to an intolerance.
Yeah, absolutely. Especially if you're taking progesterone intermittently. So if you're still having periods, you take progesterone for 2 weeks, and either 2 weeks in each calendar month, or 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off. And if you start getting that wrong, actually that can really affect how you feel, because you're going to be taking progesterone at different parts in your cycle. And it can be quite confusing. The guidance is that you start it 15 days after the first day of your bleed. So if the first day of your period is day 1, you bring progesterone in 15 days later. That's when you begin it. And that's when your natural progesterone would be rising. And then you take it for 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off. And that gives you a 28-day cycle. Or you start it on the same day each calendar month. So if your period comes on the 1st of August, you start it on the 15th of August, you take it for 2 weeks. Then you then start it on the 15th of September, you take it for 2 weeks, and so forth. And that gives you a monthly cycle. And there are some people who have very irregular periods and they don't know when their next period would come. And I would usually say take progesterone day 1 to 14 of each calendar month. And with time, your body will get used to that. It's a very nice, simple way of remembering it. But if you're taking progesterone here, there, and everywhere, your body is going to be asking you what is happening, really.
Absolutely. So yeah, difficult times for many, I know, on the call today. You've mentioned the Mirena coil, and many of us have had a coil before menopause was on our horizon, but then more recently you might have started to experience things like anxiety and mood swings, something that's never had an experience before. Could this be linked to they are starting to experience the symptoms associated with perimenopause?
Yes. And so when you have a coil put in, you are just having progesterone, and progesterone isn't the hormone that improves how you feel. It usually doesn't improve how you feel, especially the coil. Estrogen is the hormone that improves how you feel. So if you've got somebody who just has a Mirena put in, they are still going to go through that perimenopause or menopause journey, how they always would have done. So if somebody's if they've got the coil in, it will take away the periods usually, and that can make it harder to work out where you are in that transition. But if that person's starting to get anxiety or hot flushes or night sweats or muscle and joint pains, it starts to suggest that that person might be going through the menopause transition. And then it would be very easy to use an estrogen, usually a transdermal estrogen, because the Mirena can be used as the progesterone arm for 5 years. Was that the question? Have I answered that?
Yes, it was somebody who'd had a coil and lived with it very happily and kept rotating, but then in the last year or so had started to experience many of the symptoms we commonly associate with perimenopause as a say,
Yes.
that anxiety and mood swings. So it's almost, we've just got to have more, an understanding and awareness of what's changing in our body. How are we feeling, and that
Yeah.
tracking and things like that, isn't it?
Yeah, when you have that coil put in, you go through that menopause journey exactly the same as if you didn't have that coil put in. The only thing
Yeah.
it's doing is taking away your periods, but all of
Yeah.
the other symptoms would happen in the same way that with or without the coil.
Well, that's wonderful, and thank you to everybody for your questions today. We've sort of brought them together
Oh,
to
good.
answer them in a more general manner. So thank you, Dr. Abbie,
Oh,
for
it's a
joining
pleasure.
us today. As ever, very informative session, and we certainly would encourage everybody to watch the recording back, because this recording, along with all our very popular Lunch and Learns, are available to view on the Henpicked website, and of course, along with podcasts and articles from leads in the field of menopause health, including Dr. Abbie herself and her fellow doctors and specialists at My Menopause Centre. So once again, Dr. Abbie, thank you for your time today, and thank you to everybody for joining us. Thank you.
Thank you.